going to talk a little bit about setting the scene. A lot of my academic career has been around quantifying health hazards, the comparative importance of health hazards. How important is tobacco as a cause of health loss in populations compared to other things? How important is it for an individual? And how is the population exposure to things like tobacco changing? This, I think, is an important step in setting the scene, as I've called this title slide. I'm going to talk a little bit about why smoking is the dumbest thing you as an individual can ever do in terms of its health risks. I think you may know this, but it's important as you go forward in your work, you know just how hazardous tobacco is. I'm then going to talk a little bit about the perspective from politicians, from health policymakers, about is tobacco an important cause of health loss in my population and economic cost that the Minister reminded us this morning. So it's not just about counting bodies, it's also about counting dollars and look at the health implications for populations globally and regionally. I'll then spend a little bit of time talking about changes in smoking prevalence. It's all very fine to quantify the epidemiology of tobacco in terms of individual and population risks. But what does it look like in terms of population exposure to risk? Who's smoking and how is that changing? That's important for policy and certainly important to remind you in this conference just how big a task you've got. And then finally, I'm going to summarise that for the region, for Oceania, in terms of looking at the public health implications of that. So what does it mean for the individual smoker? What are the risks in terms of dying? These are data from the American Cancer Society, large prospective studies in the 1980s. It's a little bit out of date, but the message is very simple. Look at that graph. Look where the solid line is. That's a lifelong non-smoker. And the red line shows you the relative risk of dying, of dropping dead at any time, at any age, if you're a current smoker. You have a 3 times higher chance, a 200% higher chance of dying at any age, at any time, if you're a current smoker compared to a lifelong non-smoker. In other words, tobacco will kill 2 out of every 3 people, either in middle age or in old age, but it'll kill 2 out of every 3 of its users if those risks are generalisable. And now I'm going to steal some information very quickly from a fantastic study published by Richard Peto and Kirsten Peary and the group at Oxford, where they took 1 million women in the UK and followed them. I showed you American data. I'm now showing you, I'm stealing something from the 1 million women study that was published in The Lancet a couple of years ago. It shows for 2 main causes of death, heart attacks, vascular mortality, and stroke, the relative risk of death at any time, at any age, if you're a smoker compared to a lifelong non-smoker, as a function of how much you smoke. Smokers like to kid themselves. I'm a light smoker. I smoke 10 cigarettes or 5 cigarettes a day. Well, if you smoke 5 or 10 cigarettes a day, your risk of dying of a heart attack tonight is 3 times higher than everyone in this audience who I am sure are lifelong non-smokers. If you smoke 10 cigarettes a day, your risk of a stroke is 2 to 3 times higher than someone who's never smoked. And look how quickly it rises. So you get to the average level of smoking of 18 to 20 cigarettes a day, and these people are incurring risks of major vascular disease, mortality, of 5 to 6 times what non-smokers do. And if you think that's bad, look at this one. This is lung cancer. Now, tobacco kills many more people in countries like Australia from major vascular disease than it does from cancer. But the extreme hazards of a smoker compared to a lifelong non-smoker for lung cancer are extraordinary. And you can see them from this graph as a function of cigarettes per day. So a smoker smoking 2 packets of cigarettes a day has about a 35 times higher chance of dying from lung cancer, 3,400% higher chance of dying from lung cancer than a lifelong non-smoker. Why on earth would you ever do that? And so here's the summary of all-cause mortality. I showed you the American Cancer Society data. Identical risks from the Million Women study in the UK, showing also this very steep gradient. There's no such a thing as a light smoker. You're either a smoker or a non-smoker. And if you're a smoker, even smoking 5 to 10 cigarettes a day, you've a 100% higher chance of dying at any age than a lifelong non-smoker. The risks for individuals are extraordinary, but stopping smoking works. Extraordinarily important message for you as advocates and public health specialists to remind smokers that stopping smoking works. This again comes from the Williams study, and it shows that if you stop smoking by the time you're 30 and avoid most of the damage, then your risks of mortality are comparable to lifelong non-smokers. But if you stop smoking later in life at 40 or 50, your risks are high and remain high. So stopping smoking works. And finally, just from the individual perspective, this is for messages for the individual smoker. I've taken Sir Richard Dole's study in 1950 when he set up the British doctors cohort, and he followed them through, and we're still following them through 5 or 6 years after his death. We look at smokers who are in the blue line and non-smokers in the red line, and look at what happens to them from age 35 to the end of life, say 100 years on. And you can see the red line is always much higher than the blue line. In other words, the survival prospects of non-smokers are always uniformly higher than smokers. So by the time you get to age 70, 80%, 8 in 10 of the non-smoking doctors were still alive, compared to less than 60% of the smoking doctors. So an extraordinary impact on individual health. But what does it mean for populations, the health of populations like Western Australia, Australia, and the world? Here's a beautiful graph I've stolen from Mike Toon from the American Cancer Society. I like to call it the rear view mirror image. The red line there shows 100 years of per capita cigarette consumption, males and females, in the United States since 1900 right through till about 2000. Rising rapidly from about 0, these are manufactured cigarettes, to about 4,500 per adult per year, and then declining since the mid-1960s. The blue line, I think it's blue, at least the first of the white lines, shows 2 decades after the big increase in tobacco consumption in America, the big increase coming in lung cancer. It's not rocket science. If you smoke, populations start to smoke in large numbers, they'll start to die in large numbers 2 to 3 decades later from lung cancer. And if you think that just applies to men, look at the next graph. That's women. They began to smoke much later than men, mostly in the US after the Second World War, and their lung cancer rate started to rise in the early 1960s, 2 decades after. So when I was at WHO, I took this sort of information and decided to try to make a model of what happens in rich countries like Australia, New Zealand, United States, Western Europe. What happened over the last century, over the 20th century, to tobacco? And so I've modeled this out. The top line there shows male prevalence. This is something that Simon Chapman asked me to do when he was editor of Tobacco Control quite a long time ago, more than 20 years ago. I think the model still holds, although we have improved it. But look at the impact. So that American data shows us that about 2 decades after males start to smoke in large numbers, they start to die in large numbers, that green line there. These are all-cause mortality. So that at the peak of the epidemic, 2 to 3 decades after the peak of the prevalence of smoking, about 1/4 of the male population who die are killed by tobacco. And then females smoking much later and much less than men, and their mortality on the right-hand side, I overestimated. I got a bit enthusiastic about how much smoking was going to be killing women. When Richard Peto and I and others updated our book on mortality in developed countries from tobacco, we got these results that show, in general, the females, which are in the red line, were not as extreme as I had predicted, but they're still high. So what does this mean? If you look at these graphs, Australia, UK, USA, Netherlands, I don't have New Zealand, but it'd be very similar to Australia. At the peak of the epidemic in this country, that was in the, say, the 1980s, 1 in 3 men who died in Australia died from tobacco, died in middle age, died from tobacco. 1 in 3 men. And in women, the epidemic has stabilised at about 15%. So currently, about 15% of women who die in Australia in middle age die from tobacco. And you can see it's slightly more extreme in the UK. At the peak of the UK epidemic, about 10 to 15 years before Australia, almost half the men who died in middle age in the UK, 35 to 69, were killed by tobacco. So these are extraordinary population health impacts. What about the rest of the world? This is some work from the Burden of Disease study with Chris Murray. Just to summarise, if we take adults 35 and above, Tobacco generally doesn't kill you below age 35. We've noticed higher rates of mortality from murder in smokers compared to non-smokers. Richard Peto thinks that's causal. I don't think it is, although I'm sure many of us have felt that way at some time. But this shows just for 35 and above, when tobacco is established, the epidemiology in terms of its health effects. Eastern Europe, almost 1 in 5 people, this is males and females, 1 in 5 people who die are killed by tobacco. Same in Central Europe, not very much different. We drop down to Australasia there, just under 15%. Oceania is another region down towards the bottom that's primarily Papua New Guinea. It's not population weighted. So when I say Oceania, I'm going to be largely talking about what we can glean from data for Papua New Guinea. But still about 1 in 10 adults dying in Oceania today die as a result of tobacco. It is not a trivial hazard. And if we pick your favourite country and look at the percent of adult deaths today, adult deaths, this is 15 and above in this age, due to tobacco. Red is bad and blue is good. Red shows the percent greater than 20%, greater than 1 in 5 people, adults, who die in these populations are being killed by tobacco today. Look at Russia, look at Central Europe, the United States, Canada, Chile, parts of Latin America, New Zealand, parts of Southeast Asia already, Indonesia, large populations, China, where the fraction of adult deaths, both males and females combined, is at least 15% and in many cases greater than 20%. And if we just focus on males because their epidemic is more advanced, in all countries. Again, red being bad with a fraction greater than 20% of male adult deaths due to tobacco. This is 2010. It's unlikely to be very different today from the Global Burden of Disease study. You can see red everywhere. North America, Western Europe, certainly Central and Eastern Europe, China, parts of Southeast Asia. Look at Thailand, look at Indonesia. They are not escaping. They are already there, as best we can estimate, in terms of the impact of the tobacco epidemic. Australia, between 15 and 20%, just under 20% for males and even lower for females. That just shows the extent of what tobacco will do eventually in countries where the epidemic is mature, countries like Australia. So what does all this mean worldwide? Again, estimates from the GBD study. I don't know how reliable these are. Look at the size of the uncertainty intervals. I think it's important that we understand we don't know reliably how to measure tobacco deaths in many populations. We're using various approaches. But in 2010, the second line there, we estimate, Murray and I and others, that tobacco killed over 6 million people. 6 million people in 2010, up from 5 million people in 1990. You can see the split there for males and females in 1990, 2010. In 2010, about just under 2 million female deaths worldwide and just over 4.5 million male deaths worldwide. But the total annual number is over 6 million. That's about 12% of global mortality, 12%. Where's this going? I just don't know, but it's not going down. And so worldwide today, we think developed countries, about 2 million tobacco deaths. This is each year, not in a 5-year period. Each year, 2 million tobacco deaths. China, about 1 million. If we're looking at the prospective evidence that Richard Peto and others is generating. India, Prabhat Jha and colleagues showing tobacco is already a well-established hazard. The world is getting healthier. Child mortality is coming down. It's come down from 16 million deaths a year when I first joined WHO in 1980 to less than 6 million deaths. We are being very successful in keeping babies alive into adolescence. We're being much less successful in keeping adolescents alive into old age, and tobacco has a lot to do with that. Where's it going? It's 6 million today. It's gone up 10 million gone up 1 million in the last 20 years. What will it do in the next 20 or 30 years? By 2050, Peto and I predict on current trends, the annual mortality from tobacco won't be 6 million. It will be closer to 10 million unless we can do something about it. 10 million deaths a year, that's absurd. And that's something that this conference needs to take very seriously. So what does the use of tobacco look like worldwide? Summarised here in a paper we did for the JAMA edition on the 50th anniversary of the American Surgeon General's report, just to show that the males are in blue, females are in orange on that left-hand graph, we are seeing generalised drift downwards in smoking prevalence. This is age-standardised smoking prevalence from 1980 on the left-hand side down to 2012. For males, it's very similar for rich and poor countries, so the global average is right in the middle. For females, we have rich countries in the top orange dots. Developing countries, females, notice that not many of them are smoking yet, and fewer seem to be smoking year by year. We've got a slight drift down so that the global average for female prevalence is under 10%. But what's worrying is the next graph, and that's the annualised rate of change between 1980 and 2012. The annualised rate of change in smoking prevalence, males in blue, females in orange, has been going down to the point, say, by 1996, tobacco prevalence was falling worldwide by about 2% a year. We were doing quite well. And we did quite well up until about 2005, where tobacco prevalence was falling about 2%, 2 to 3% a year. Since then, worryingly, it has been falling at a slower rate. It's still falling for females, but it's not falling any longer for males. And those trends upwards in the rate of decline of smoking prevalence, particularly for men, ought to sound alarm bells for us. Here's what it looks like worldwide. Again, pick your favourite country. Red is very bad. The dark red means that males, adult males in these populations have at least 1 in 3, 30%, 35% prevalence. And in some cases, like Indonesia, 60% of adult men smoke daily. The mortality from smoking in Indonesia is about to get very massive. And then you can see Central Europe, China, also very high prevalence, very dark red. Australia and New Zealand in the lighter colours showing the success that we've had. If we look, that's for men. For women, generally lower prevalence, so much more blue than red. A few red areas, look at France, parts of Central and Eastern Europe. Even the UK is still not as low as it might be. Australia in light blue, Canada, United States, much of Latin America, and indeed much of Africa, where female prevalence is still, thankfully, very low. Notice PNG, as best we can measure from the STEP survey, female prevalence is not low. Just to have a generalised look at the drift of the lines, there's a couple there that really matter. Somewhere at the top there is Oceania. It's absolutely flat. As best we can estimate, between about 1970 and 2010, 2015, there's been no change whatsoever in smoking prevalence in males and females in Oceania. 40% of males smoke, 20% of females smoke. It seems to have been the same all the way through. Australia, and New Zealand, Australasia, the light blue line there, very substantial and pleasing declines in smoking prevalence. One thing I want to clear up is that we think, well, if a country's high, it ought to have bigger declines in smoking prevalence just if we introduce the right tobacco control measures. That is not the case. This graph shows for men on the y-axis the rate of change, the annual rate of change since 1980, and the x-axis, the horizontal axis, shows the prevalence of smoking in 1980. And no matter where you started from in that prevalence, be it low, around 10% in Antigua, up to 65% in Japan and Poland, your rate of change is unrelated to where you started on that graph. And the correlation is about 0.26. Notice that the countries above the line there in orange, Saudi Arabia, Kazakhstan, etc., have had significant increases into smoking prevalence over the last few decades. Most countries are either no change or have been drifting down. And the same for women. The graph is a bit tighter, but again we see no relationship between the level of smoking of women in 1980 and the rate of change. What we do see is a worrying group of countries above the horizontal line, marked in yellow there: Austria, Greece, Bulgaria, France, Tonga, Portugal, Costa Rica, Tunisia, etc., where there have been significant increases in smoking prevalence over the last 2 to 3 decades. So what does all that mean? It's very hard to take that in. Let me try and summarise for you. Annualised rate of change in smoking is largely uncorrelated with where you start from. Interesting finding and important for us. For men, annualised rates of decline of 2% or more have occurred in 17 countries, but statistically significant increases in prevalence for men in that bunch of countries there, very diverse. For women, we've had annualised rates of decline greater than 2% in 22 countries, but prevalence has increased in 12 of these. And I'll just draw your attention down to the bottom there. Austria, Bulgaria and Greece had prevalence rates greater than 20% for women in 1980, but nonetheless still showed significant increases since then. So it is possible to be high and to get higher in terms of smoking prevalence. In terms of global tobacco trends for this part of the talk in terms of exposure, global age standardised prevalence of tobacco has declined. This is a pleasing trend, a good trend, as best we can measure it, by about a quarter in men and by about 40% in women, but it was starting from a low base. However, because of population growth, the number of daily smokers is now about 1 billion worldwide. It's gone up 40% in men and a little bit, much less than that, 7% in women. Worryingly, the pace of reduction in prevalence has slowed down dramatically since 2006. Prevalence rates between men and women are only weakly correlated. Because its prevalence is high for men does not mean it will be so for women. And 4 countries, and it's worth naming them because these are the real standouts in terms of global tobacco control. They have been successful in achieving reductions of greater than 50% for both male and female prevalence over the last 3 and a bit decades. Canada, Iceland, Mexico and Norway. Australia is in the next band, but it does not reach the levels of these countries. So very quickly then, just to summarise and remind you as you go forward in your talk, why tobacco control matters. These are estimates with great uncertainty because of the quality of data that Murray and I and others have produced for the burden of disease. And these are very recent for 2013, published this year in The Lancet. This is Papua New Guinea. Smoking, we consider to be smoking in PNG the leading risk factor, more than malnutrition, more than water and sanitation, the leading risk factor for disease burden in Papua New Guinea. So is high fasting plasma glucose, high body mass index, high blood pressure, and then we can see water and sanitation up there as well. But smoking is non-trivial as a cause of disease burden in PNG. It's the 3rd leading cause we consider in Tonga, accounting for about 15%, about the same as diabetes, about 15% of the entire disease burden in Tonga. In other words, the Tonga population, I hope there's some people here from Tonga, would be 15% healthier in 2013 had no one ever smoked. So these are non-trivial causes of disease burden. And here's Fiji, where it's a little bit less, about 10%, but still in the top 5 causes of disease burden. I've only shown those as an example. It's a very, very similar story throughout the region. Indeed, in 1990, this graph shows males on the left, females on the right, the fraction of deaths due to tobacco in these countries in 1990. For females, it's about 2 to 5%. For males, it's between 5 and 15%. But look what happened by 2013. Our estimates are that tobacco mortality has increased substantially in Oceania over the last 10 to 15 years. So now it's causing, in countries like Samoa, Micronesia, we estimate that about 1 in 7 male deaths, 1 in 7 male deaths currently are due to tobacco. And in the worst case, Tonga, for females, 1 in 10 female deaths in Tonga is currently attributable to tobacco. To summarise for the region and why this conference matters, why tobacco control matters and continues to matter for Australia and New Zealand. 7 to 17% of male deaths in this region are due to tobacco and up to 10% of female deaths, generally much lower, but in some cases almost 1 in 10, as in Tonga. It's expected to get much worse. There's nothing special about lungs and hearts in this region. If they react the same way as British lungs and American lungs and hearts, then we'll see the same health effects. It's going to get much worse. At the height of the epidemic, 1 in 3 male deaths in middle age was caused by tobacco in Australia and a bit worse in the UK. Will it be the same in the Pacific? There's been little change as far as we can see in what I'd classify as high smoking prevalence in this region. There's been massive declines, on the other hand, as we know about, in Australia and New Zealand, followed by massive declines in premature mortality and economic costs from that. Stopping smoking works. 3 key words that really need to underlie your work with populations. The earlier you stop smoking, the better it is in reducing risk. And stopping by age 30, being sensible and stopping by age 30 reduces most of the risk. More effective prevention is urgently needed. That's nothing new, but I need to underline it. We know what works. I'm about to show some examples, and you probably know this very well. Bold public policy, and bold ought to be bolded because that's what it takes. Bold public policy can prevent the 1 in 3 deaths in middle age that are about to occur in this region in our lifetime, unless we are successful in reducing tobacco. Here's what the UK have done. This is UK tobacco consumption back at the end of the 19th century, right through to 2010. This is cigarettes per day on average per adult, 15 plus. Look at the massive rise up until about 1980, and then the massive decline. It's declined by 50% and it's falling. This is the United States, an identical pattern using a slightly different metric, cigarettes per adult per year. You can see it rising from 1900 from about 0 right up to over 4,000 cigarettes per adult per year at the time of the Surgeon General's report in 1964, and then the massive declines since then. And you can see all of the interventions, the impact of interventions. We must not be fooled into trying to quantify what one particular intervention can do. Look at the cocktail of interventions and look at the impact it's had in the United States, look at the impact it's had in the United Kingdom, and look at the impact that it's had in Australia. This is a much more recent view of tobacco control in this country. Tobacco prevalence since 1990 to 2013 has fallen from 26% to 13%. It has halved at a relatively low level. It has halved and it's going down, and that is a litany of all of those wonderful measures that we've got written there on the slide these are bold public policy that need to be implemented, and all of them, including plain package, need to be implemented. So in finishing, I just want to remind you my work in global health suggests there are 4 great epidemics in our lifetime. HIV, it's an epidemic that's caused massive mortality, premature mortality, particularly in Africa. It's not over yet. We must not take our eye off the ball. We need to build on the fragile but important progress that's happened in the last 10 years. Diet and adiposity, the world is getting fatter. It's quite clear that the health effects of diet and adiposity have not yet played out in populations. We all need to eat, but we need to eat wisely. Alcohol is a 3rd great epidemic. I don't know whether we all need to drink. I feel like we need to do that sometimes. But if we're going to drink, let's drink wisely. And then the 4th great epidemic is tobacco. We don't need to smoke. We absolutely don't need to smoke. It is the single greatest epidemic, public health epidemic of the 20th century. It will be, by far, the single greatest epidemic of the 21st century. Pito and I estimate it killed 100 million people last century. It will kill 1 billion people this century unless we're able to do something about it. This conference is a great place to start. Thanks very much.